Welcome, everyone, to Webinar Wednesday. We are very excited to have Dr. Pamela Smith spend lunch with us today as she shares her expertise in PCOS. Dr. Smith spent her first 20 years of practice as an emergency room physician with the Detroit Medical Center and then 28 years as an anti-aging functional medicine specialist. She is a diplomat of the board of the American Academy of Anti-Aging Physicians and is an internationally known speaker and author on the subject of precision nutrition. She also holds a master's in public health degree, along with a master's degree in metabolic and nutritional medicine. Dr. Smith is in private practice and is the senior partner for the Center of Precision Medicine with offices in Michigan and Florida. She has been featured on CNN, PBS, and many other television networks, has been interviewed in numerous consumer magazines, and has hosted 2 of her own radio shows. Dr. Smith was one of the featured physicians on the PBS series, The Embrace of Aging, as well as the online medical series, Awakening from Alzheimer's and Regain Your Brain. Dr. Pamela Smith is the founder of the Fellowship in Anti-Aging, Regenerative, and Functional Medicine, and is the past co-director of the Master's Program in Metabolic and Nutritional Medicine at the Morsani College of Medicine, University of South Florida. She is the author of 11 best-selling books. Her book, What You Must Know About Vitamins, Minerals, Herbs, and So Much More, was published last year. Her newest book, Max Your Immunity, has just been released. Her new PBS CNN special will be aired this fall. Dr. Smith, welcome and thank you for being with us today.
Thank you so much, Lindsay. Hello, everybody. It's great to spend lunchtime with you. PCOS, otherwise known as polycystic ovarian syndrome, is really quite fascinating. It used to be called Stein-Leventhal, and when I was in medical school 47 years ago, what they said to me was the following: you will see about 2 cases of Stein-Leventhal in your entire career. Well, PCOS, its new name, not so new anymore, I see 10 cases a week. It is the most common endocrine disorder in women of reproductive age worldwide. It does affect nearly 10% of women in the US. It accounts for 75% of the women with amenorrhea, and it also accounts for 85% of women with androgen excess and hirsutism. The definition of PCOS has changed over time. Currently, there are 3 criterion set up by the National Institutes of Health: irregular or absence of menstruation, excessive androgen production, and lack of other reasons for irregular or absence of cycles and excess androgens. So that's the current definition of polycystic ovarian syndrome. Initially, having ovarian cyst was not one of the 3 criterion for the diagnosis. Therefore, ovaries with many cysts does not necessarily mean the patient has PCOS. They do have to have high androgens. The consensus workshop sponsored by the European Society of Human Reproductive and Embryology and the American Society of Reproductive Medicine in 2003 agreed upon a new definition. And the patient has to have 2 out of these 3: oligoovulation or anovulation, clinical or biochemical signs of excess androgen activity, and now they did add in the cyst. But again, it's 2 out of 3. So technically, the patient doesn't have to have polycystic ovaries to have this diagnosis. What are the signs and symptoms of PCOS? Obesity and inability to lose weight is quite common. High hip to waist ratio, BMI greater than 30, irregular or absent menstrual cycles, infertility, recurrent miscarriage, hirsutism, oily skin and acne, alopecia, skin tags, acanthosis nigrans, depression, irritability, and just general tension. There can be gray white breast discharge, sleep apnea, pelvic pain, thinning scalp hair, which gets many women. That's a huge complaint. And there can even be an epilepsy connection. 40% of women with hirsutism who have normal cycles are anovulatory, meaning they don't cycle at all. Acne is seen in 1/3 of the patients with PCOS due to the high androgens, and many women with severe acne do have PCOS. Hirsutism and acne are present in 70% of women with polycystic ovarian syndrome and 10% of women without the disease. Hirsutism is present in 70% of women in the US who have this disease, but very interesting, hirsutism is seen in only 10 to 20% in women in Japan who have the disease. And this may be due to the difference in the genetic changes in 5-alpha reductase activity in the different cultures, or it may be due to the differences in diet between Japanese and American women. If I had to guess, it's actually probably due to both. Infertility affects about 75% of women that are obese with PCOS, and weight gain is usually around the waist, as opposed to overall weight gain. Women with epilepsy have a 10 to 26% higher risk for PCOS than other women. About 40% of women treated with valproate for epilepsy have polycystic ovaries, and 17% have high testosterone levels, but do not have polycystic ovaries. Perhaps the numbers are actually higher if all GYNs and all neurologists actually looked for polycystic ovaries and for signs of hirsutism. Laboratory testing abnormalities, there are a myriad of them. High testosterone levels or other androgens, such as androstenedione, elevated insulin level and insulin resistance, an elevated LH to FSH ratio. So you have a higher LH and a decreased FSH, lower sex hormone binding globulin. If you have lower SHBG, then testosterone levels go up. It makes more testosterone available for the body to use because less is bound. There's commonly an abnormal lipid profile. There's elevated DHEA levels and high estrone. Remember, there are 3 estrogens, E1 estrone, E2 estradiol, E3 estriol. The estrone one being high, this is the one that is linked to an increase in breast cancer. So we want to go back and help these patients balance their hormones. And that's honestly what I just love about anti-aging medicine. We really are the people that are on the forefront of hormonal balance. So what's the physiology of normal menstrual cycle? GnRH, gonadotropin-releasing hormone, is secreted from the hypothalamus, but it's a pulsatile secretion. The GnRH stimulates the pituitary to release FSH and LH, which act upon the ovaries. LH stimulates the production of androgen and progesterone by the theca cells, and FSH stimulates the production of aromatase in the granulocells, which are needed for the conversion of androgen to estrogen. Continuing on with the physiology, local estrogen stimulates the development of a follicle. Non-aromatized androgens inhibit growth of the follicle. So the ovary has a feedback mechanism that regulates the decline of FSH as the follicle matures. When estrogen reaches the right concentration, LH surges. This triggers ovulation. After ovulation, progesterone is secreted by the corpus luteum. So what is the actual physiology of PCOS versus normal menstrual cycle? In PCOS, the GnRH pulsatile frequency is higher. There is an increasing circulating of LH and decreased FSH. This leads to excessive production of androstenedione and testosterone. In the absence of total suppression of FSH, there's continued follicular growth, but the follicles do not mature. This results in atresia of the developing follicles. So polycystic ovary is due to chronic anovulation. The circulating estrogen levels are higher. This is due to an increased in peripheral conversion of the higher amounts of androstenedione to estrogen, mostly as the estrone component. Since progesterone is low or absent in these patients, there's an increased pulsatile secretion of GnRH from the hypothalamus. This contributes to higher LH and lower FSH, which then continues this whole situation, and you get into kind of a catch-22. What are the actual causes or etiology of PCOS? Many scientists believe the PCOS has a hereditary component. 40% of women with PCOS have a sister with the disease, and 35% of women with PCOS have a mother with the disease. There is some suggestion in the medical literature that women with PCOS are born with a gene that triggers higher than normal levels of androgens or insulin. And studies have shown that high levels of testosterone and insulin in patients with PCOS are linked, and that link is a gene called follistatin. What does follistatin do? It plays a role in the development of the ovaries, and it's also needed to make insulin. This is a very important link that occurs. So, women that are overweight and women that are not, that have PCOS, both have a higher rate of insulin resistance and hyperinsulinemia than controls. So, in other words, when you first see the patient, should you be looking at measuring fasting blood sugar, fasting insulin, hemoglobin A1C? Absolutely. And as you all know, in anti-aging medicine, we look for optimal levels. The fasting blood sugar should be in this age group between 70 and 85. The fasting insulin, perfect is 6, too high or too low is leading toward or is insulin resistance, and the perfect hemoglobin A1C is 5.4. If you're joining us today from Canada or another country, the units may be slightly different. Please contact Lindsay and we will have a conversion table for you if you would like one. Insulin decreases sex hormone binding globulin, which does increase the levels of the circulating testosterone, as we mentioned. Insulin works with LH to increase androgen production in the ovarian thecal cells. So, still looking at the causes, it is suggested that women with PCOS have a hyperactive production of CYP17 enzyme. This is responsible for forming androgens from DHEAS at those sites. This mechanism is further exacerbated when the patient is obese, and DHEA is elevated in 50% of women with PCOS. Now, that's not taking into account the study here by Spiroff was not taking into account that DHEA could also be elevated due to stress. And certainly in this era of COVID and post-COVID times, we are looking at many people, maybe even most, having high DHEA and abnormal cortisol. Higher DHEA is due in polycystic ovarian disease to stimulation with ACTH produced by the pituitary, mainly due to stress. So the excess DHEA is then converted into androgens via the adrenal metabolism. So that's where it gets into the adrenals here. This contributes to higher androgen levels in this disease. High testosterone levels correlate to the high LH levels, and higher androgen levels in the ovary inhibit FSH, which then inhibits the development and maturation of the follicle. So almost done here with the causes, but the metabolism of estrogen then changes by the way of the 2-hydroxylation and 17-alpha oxidation pathways, which are decreased. Remember, we want the 2-hydroxyestrogen to be higher. That decreases the risk of breast cancer. Estrogen levels increase due to peripheral aromatization of the androstenedione. This results in estrogen dominance due to the overproduction of estrogen. So commonly the picture you're going to see: high estrogen, low progesterone, high testosterone. The skin and adipose tissues are also postulated to contribute to the etiology of PCOS. Women who have hirsutism have an elevated sensitivity to androgen activity in the skin, so they may develop abnormal patterns of hair growth. Aromatase and 17-beta hydroxysteroid activities are increased in the fat cells, and peripheral aromatization increases with the increase in weight. Also, phthalates, bisphenol A, cadmium, and mercury toxicities have been related to PCOS. Do I measure phthalates, bisphenol A, and toxic metals in every single patient with PCOS? No, but perhaps we should. Altering hormones to cause anovulation, these changes increase the development of insulin resistance and high androgens. The imbalance in the HPO axis that occurs in PCOS is part of the etiology of disease. 25% of women with PCOS do have hyperprolactinemia. So measure prolactin. The hyperprolactinemia is due to the abnormal estrogen negative feedback from the pituitary. An elevated prolactin can contribute to high estrogen. It also contributes to low progesterone. And of course, stress can be a contributing factor to PCOS. I honestly think stress is probably a contributing factor to every disease process there is. A study showed that many women with PCOS cannot process cortisol effectively. I'm going to say that again because it's so important. This study from 2003 showed that many women with PCOS cannot process cortisol effectively. This leads to increased cortisol levels in the body. So it's actually part of what happens in this disease process. When women are under stress, too much prolactin can also be released, and this can affect the ability of the ovaries to produce the right balance of the hormones. And of course, thyroid. Thyroid is the conductor of the hormonal symphony. Hypothyroidism can be a cause of PCOS. This study, done on teenage girls with polycystic ovarian syndrome, showed that on ultrasound, the ovarian cyst resolved when their hypothyroidism was treated. LH levels also decreased. This study, done on women with hypothyroidism that were given levothyroxine alone or clomiphene citrate and or dexamethasone, ovulation was normalized. Study of women with PCOS, 27% of them had elevated thyroid antibodies. Of course, that's not surprising when we look at hypothyroidism. In fact, the current data is for all comers of people with hypothyroidism, 75% of them have Hashimoto's thyroiditis, otherwise known as elevated thyroid antibodies. 42% in this study had a hypoechoic pattern on thyroid ultrasound, which was consistent with autoimmune thyroiditis. And women with PCOS were found to have a prevalence of autoimmune thyroiditis that was more than 3 times higher than controls that did not have PCOS. If it's an autoimmune process going on, we always do 3 things. And you'll learn more about this in the module on autoimmune disease. But we do 3 things: take the patient off of gluten. 2, fix the gut. 3, start low-dose naltrexone. Still looking at causes. This 2016 study. Disturbed ovarian pituitary and hypothalamic feedback accentuates the gonadotropin abnormalities in patients with PCOS. And this is encouraging and emerging evidence that the implication dysfunction is in the KIS-1 system. So what is the differential diagnosis? It's actually quite huge. Hypothyroidism, hypothalamic amenorrhea, Cushing's syndrome, congenital adrenal hyperplasia, ovarian and adrenal tumors, do not forget that, hyperprolactinemia, and premature ovarian failure. There are definitely multi-system features of this disease. So it's not just, hi, let's see the patient, start oral contraceptives. That's not what we do in anti-aging medicine. We look at the cause of the problem. And now there's more growing awareness of the multi-system features of this disease. There is a higher relationship with the HPOA functional disorders. This results in high androgens, high insulin, increased estrone, luteinizing hormone, FSH ratio imbalance, infertility, cardiovascular disease, endometrial dysfunction, obesity, and other health issues. This is from a 2019 study. Patients who have PCOS are at a risk factor for other major diseases: infertility, hormone-related cancers, obesity. Let's look at some of these. PCOS is a risk factor for diabetes. If the patient has PCOS, they are 7 times more likely to get diabetes. And about half of all women with PCOS have insulin resistance. Some studies suggest that women with polycystic ovarian have irregular cycles or no cycles may have double the risk for diabetes, and the risk factor for diabetes in patients with irregular cycles increases even more if the patient is obese. The risk of getting diabetes is also increased in these patients, even if they're not overweight or insulin resistant. So keep that in mind. How about heart disease? Women with PCOS have an increased risk of heart disease compared to women without PCOS. In fact, up to 70% of women in the US with PCOS have some sort of dyslipidemia. We see this even in 18-year-olds. They frequently have elevated total cholesterol, LDL, and triglycerides. They tend to have low HDL and apoprotein A1. Patients with PCOS also tend to have impaired fibrinolysis, as evidenced by elevating circular levels of plasminogen activating inhibitor. This is associated with heart disease and hypertension. Women with PCOS have a 7-fold risk of having an acute MI. They also tend to have high homocysteine levels. Patients with high homocysteine have an increased risk in heart disease, stroke, bone loss, breast cancer, cognitive decline. So it's imperative we measure homocysteine levels in these patients. Homocysteine should be 6 to 8. Too low of homocysteine means that they're overmethylated. And yes, you can be overmethylated. Too high means they're undermethylated. I actually happen to be one of those people. I didn't have PCOS, but I do have a high homocysteine. Fortunately, when I came to the very first anti-aging conference, I learned that. And I went back, measured my homocysteine. It was 16. So I've been taking methotetrahydrofolate now for, twice a day since the beginning of anti-aging medicine. Women with PCOS have a higher than usual rate of elevated CRP as well. So measure homocysteine, measure C-reactive protein. Women with PCOS frequently have decreased total antioxidant status and an increase in oxidative stress. This pattern may be one of the contributing factors to their increased risk in heart disease. So it's now suggested that routine screening for metabolic syndrome be done even in adolescents with PCOS. How about hypertension? Women with this disease have 4 times the rate of hypertension than women who do not have PCOS. Insulin resistance and hyperinsulinemia also raise blood pressure. How does this happen? High levels of insulin correlate with low sodium in the urine. This leads to an increase in water retention, which makes it harder for the blood to flow through the circulatory system. This leads to an increase in blood pressure. It also, insulin elevates blood pressure by affecting the elasticity of the arterial walls. Insulin alters mechanical action of the blood vessel walls by acting on smooth muscle cells. It stimulates them and it makes them larger. As the smooth muscle cells grow, they make the arterial walls thicker, stiffer, and less supple. This forces the heart to work harder and exert more pressure to force the blood through the narrowed vessels. In women with PCOS, infertility becomes a problem. The ovarian follicles start to mature, but fail to ripen or to be released. They stay in the ovaries and continue to produce estrogen, but no progesterone. And elevated levels of LH and estrogen have been found in these patients. What does that do? It blocks ovulation. Higher than normal levels of testosterone in these patients also inhibits ovulation. And women with PCOS may miscarry at a higher rate than women without this disease. Still looking at infertility, it does play insulin a role in ovulation. The ovaries have insulin receptors, and insulin stimulates an increase in LH and androgen levels, decreasing sex hormone binding globulin. So in the presence of elevated androgens, LH levels increase. This leads to poor follicle development and failure to ovulate, hence the infertility. Women with PCOS do have a higher rate and increased risk in developing hormonally related cancers. Women with a history of PCOS and irregular periods have a 5-fold increase in endometrial cancer. They also have an increased risk of ovarian cancer and an increased risk for breast cancer. They tend to be overweight, have hormonal changes that lead to unopposed estrogen in the body. And then obesity. Studies have shown that women with PCOS store fat better and burn calories at a slower rate than women who do not have this disease. It actually seems unfair, doesn't it? So what do we do? Now that you know the pathophysiology of this disease, you know that these patients are at increased risk of developing heart disease for many, many reasons, an increased risk in developing hormonal-related cancers. What do we do with the management of PCOS? We're going to look at medications, fiber, low glycemic index program with weight loss, reducing stress, essential fatty acids, drinking enough water, nutrients, and beneficial herbal therapies. Detoxification, acupuncture, and weight loss surgery. That would not be our favorite choice. These medications have been used to treat PCOS. Some of them are off-label. They are used for many different reasons. There's more. So that's your traditional approach. Ovulation inducers, and of course, surgery can be done. Studies looking at the management of PCOS, statin drugs and metformin. This again would be off-label. Combined statin and metformin therapy can improve lipid and inflammation parameters. However, cannot effectively improve insulin sensitivity, and reduce hyperandrogenism in women with PCOS, according to a clinical trial. Metformin is commonly used for these patients. Do not forget that metformin, again, is off-label for this purpose, commonly is used. I do use it, but always give 100 milligrams of coenzyme Q10 and B complex vitamins twice a day, because metformin depletes the body of CoQ10 and B vitamins. Some studies have shown strong evidence supporting the use of metformin as a primary ovulatory agent in women with PCOS, particularly in relationship to fertility. Fiber. Fiber does lower blood sugar, blood pressure, and cholesterol. That's soluble fiber. And of course, a low glycemic index program is key. Patient needs to get rid of potatoes, rice, corn, and other high glycemic index foods and exercise. A small trial, 18 women with PCOS, 6-month weight loss program, 11% reduction in central fat, 71% improvement in insulin sensitivity index, 33% decrease in fasting insulin levels, 39% decrease in LH levels, and a 50% of the women started ovulating. Wow! This is just by low glycemic index and moderate exercise. This study showed that women weight loss alone helped them get pregnant in 60% of the cases without doing anything else. And weight loss in patients with PCOS can improve all of these things. High androgens, menstrual irregularities, high insulin does help restore ovulation and fertility in many patients, not all, but many. It improves gonadotropin pulsatile secretion. It can help prevent non-insulin dependent diabetes and coronary artery disease, and decreases ovarian P450C17 alpha activity. This study from 2019 showed that lifestyle intervention may improve the free androgen index, weight, and BMI in women with PCOS. Another study showed that despite high attrition, successful weight loss was achieved by 63% of women with PCOS in a clinical research setting. Now, of course, in that setting, we were encouraging people to do weight loss. Higher baseline depressive symptoms were associated with greater attrition, and higher appointment attendance was associated with lower attrition and greater weight loss success. Of course, this study was done by just looking at diet alone. It did not go back and balance the hormones. Exercise, of course, is very important. There's several studies showing that women with PCOS who exercised improved ovulation, reduced insulin resistance, and promoted weight loss. This study, the effects of exercise versus low-calorie diet, women that exercised had higher ovulatory rate, better insulin sensitivity, and larger reduction in waist circumference. How about exercise alone? In this 2019 trial, statistically significant improvement in menstrual cycle pattern, hirsutism, body mass index, weight, waist circumference, waist to hip ratio occurred when the participants exercised. The same trial showed the addition of metformin resulted in added benefits on the menstrual cycle, hirsutism, weight, body mass index, waist circumference, waist to hip ratio, serum testosterone, and oral glucose tolerance test. And of course, don't forget the Q10 and the B vitamins. Reducing stress. Cortisol does stimulate the release of glucose, fats, and amino acids for the production of energy. During times of stress, cortisol and insulin levels tend to go up, so does cholesterol. So go back and rebalance all of the hormones. Drinking enough water. The amount of water, if people have normal renal function, they don't have congestive heart failure, etc., that people need to drink is 1/2 their weight in ounces every day. That means water, water, water. It does not mean any other drink. In this study, people who drank 5 to 8 glasses of water a day had fewer heart attacks. Vitamin D. Oh my gosh, vitamin D is actually a prohormone or hormone. We probably can't say enough about vitamin D. We could spend the entire day talking about vitamin D and not just our lunch hour. Vitamin D plays a physiologic role in reproduction, including ovarian follicular development, luteinization via altered AMH signaling, follicle stimulating hormone sensitivity, and progesterone production in the human granulosa cells. It also affects glucose homeostasis. This study supports the benefits of vitamin D supplementation on hepatic markers and modest improvements in insulin sensitivity in vitamin D deficient women who had polycystic ovarian syndrome. And this is from Nutrients 2019. In this 2018 meta-analysis, it demonstrated that vitamin D supplementation in women with PCOS resulted in improvement in their C-reactive protein, MDA, and total antioxidant capacity. It did not affect nitric oxide and glutathione levels. How about vitamin D and a probiotic? When people ask me, is it more important to be hormonally balanced or more important to have a healthy gut? Honestly, the patient is not healthy until both are achieved. In this randomized, double-blind, placebo-controlled trial was carried out on 60 subjects, administration of vitamin D and a probiotic for 12 weeks to women with PCOS had beneficial effects on mental health parameters, serum total testosterone, hirsutism, C-reactive protein, plasma total antioxidant capacity, glutathione, and MDA levels. Again, a 2019 study. In this study from 2018, vitamin D and omega-3 fatty acids, the co-administration of these two things, 12-week study, beneficial effects on mental health parameters, serum total testosterone, everything you saw in the previous study, and gene expression of interleukin-1 and VEGF among women with PCOS. And of course, essential fatty acids. Every single patient in my practice is on 3 things, no matter what they come in to see me for: a multivitamin, omega-3 fatty acids, and probiotics. When you look here at essential fatty acids, they slow down the absorption of carbs into the bloodstream. They also decrease inflammation, which is beneficial in patients with PCOS, since there is an inflammatory component to this disease. A study showed that calcium plus vitamin D supplementation for 8 weeks among women that were vitamin D deficient had beneficial effects you see listed here. It affected insulin positively, it affected lipids positively. It did not affect the actual glucose. How about probiotics and symbiotics? This combination improved glucose homeostasis parameters, hormonal and inflammatory indices in women with PCOS. In fact, the inflammatory component has become so big now related to PCOS that I've actually started giving low-dose naltrexone as well for PCOS. Symbiotic pomegranate juice. Wonderful. Helps with blood sugar, actually decreases hardening of the arteries. In this study from 2019, it helped with insulin resistance, testosterone level, BMI, weight, and waist circumference in people with PCOS. Selenium. Now, selenium you have to measure. If you happen to be practicing where I practice in Michigan, we are a low selenium state. So almost everybody here has low selenium. We commonly give 200 micrograms. If you're in North or South Dakota, you're a high selenium state. Almost everybody's high there. They don't need selenium supplementation. But the patient can become toxic. So make sure you measure. In this study, 200 micrograms, 8 weeks in patients with PCOS. The women had beneficial effects on insulin parameters, triglycerides, VLDL levels, but it did not affect glucose and other lipid profiles. Chromium. Now, chromium is something we commonly use at 800 to 1600 micrograms to help regulate blood sugar. Here, it improved the HOMA score. There's no significant effect of chromium on the fasting insulin and insulin sensitivity index. That's what was found in this 2018 trial. I do have to say, in my personal practice, I've had better success with chromium in all patients than what is quoted here. D-chiroinositol, placebo-controlled trial, 44 women. Half of them received D-chiroinositol. Insulin and testosterone levels were lowered in all women, and 18 of them ovulated. Now, D-chiroinositol is not available in all countries, so depending on where you're joining us from today, this one may or may not be available. And evidence does suggest that insulin resistance seen in these women may be partially due to a deficiency of D-chiroinositol containing phosphoglycan, or a defect in its tissue availability or utilization. There has been concern by some practitioners that high consumption of inositol may exacerbate bipolar disorder. And I absolutely would not disagree with that. So this is one to use with caution. And acetylcysteine. Studies have shown that using NAC in conjunction with clomiphene citrate increased ovulation and pregnancy rates in women with infertility that had PCOS that could not conceive with the use of clomiphene by itself. I should mention with NAC, long-term use does deplete the body of different nutrients, zinc being one of them. If you're going to give zinc, you do have to give copper. Also, long-term use can precipitate cysteine kidney stones. If the patient is predisposed to cysteine kidney stones, then giving 1,000 milligrams of vitamin C a day does try and help prevent those stones. How about magnesium and vitamin E? Studies show that magnesium and vitamin E given together 12 weeks in these patients had beneficial effects on parameters of insulin metabolism and some markers of cardiometabolic risk. And then, of course, herbal therapies. Adaptogenic herbs have been shown to improve the stress response, the HPA function, American ginseng, ashwagandha, traditional ginseng as well, rhodiola. We could go on and on. Black cohosh binds to estrogen receptors and lowers it. Black cohosh can be effective in people with PCOS, as can chasteberry. Chasteberry reduces prolactin secretion since it has dopamine agonist activity on the hypothalamic pituitary level. It lowers the estrogen-progesterone ratio, and it indirectly increases progesterone. Saw palmetto. This is a great inhibitor of 5-alpha reductase, which inhibits the conversion of testosterone to DHT. It also reduces androgen effects on the hair follicle, and it does help prevent acne. Nettle root binds to and increases sex hormone binding globulin, which decreases the amount of available testosterone for the body to use. That does have to be the root. The nettle leaf does not work. Green tea increases sex hormone binding globulin, which decreases testosterone, and green tea also helps promote weight loss. In this placebo-controlled trial of women with PCOS, it showed the body weight of the group that used green tea decreased by 2.4%. The weight and BMI of the control group was higher at the end of the study. They used 270 milligrams of EGCG. Licorice root. This can decrease testosterone synthesis. Do not use licorice in people with hypertension. If they develop hypertension on licorice root, then you do have to take them off. 2-month study, there was a reduction in testosterone levels. Spearmint tea lowers testosterone. It can raise FSH and LH, and it may improve hirsutism. Maitake mushroom. Now, of course, you don't use this in people allergic to mushrooms. This study compared people with PCOS that were given maitake mushroom extract versus clomiphene. After 3 cycles, the rate of ovulation in the maitake group was 76.9%. Rate of ovulation in the clomiphene group was 93.5. You actually got a really decent response by the maitake mushroom. Proposed mechanism of action is that it enhances insulin sensitivity. White peony has a lot of functions. It increases progesterone, reduces elevated testosterone, modulates estrogen and prolactin. It affects the ovarian follicle because it affects aromatase. So it helps with androgen excess, hyperprolactinemia, endometriosis, and ovarian failure. Traditional Chinese formulation that's listed here, otherwise known as TJ68, is really a decoction of glycyrrhizin and peony. Clinical trials have shown that it's very effective, lowers testosterone, regulates LH and FSH ratios, increases ovulation and conception. Nutritional things that help regulate blood sugar. If you help regulate blood sugar, the patients do improve. Berberine is one of my favorites. It lowers fasting blood sugar and may regulate insulin receptor transcription. Chromium, as we mentioned before, great alpha lipoic acid. 300 milligrams a day of alpha lipoic acid. Helps with the liver, improves insulin sensitivity, helps prevent neuropathy. CLA can improve insulin sensitivity. Zinc can help balance blood sugar. Taurine. When patients are stressed, they get low in B vitamins. They also get low in taurine. It's an amino acid. You can certainly measure amino acids. As long as the patient has normal renal function, 500 milligrams of taurine can be very beneficial in these patients. It increases the activity of insulin receptor. It improves sensitivity to insulin. Magnesium, it has 400 functions in the body. You can't go wrong with magnesium threonate or magnesium glycinate. I usually start at 400 milligrams and go upward. So I have some patients on 1,200, 1,600 milligrams. Now, if the patient develops loose stool and they still need more magnesium, because you've measured RBC magnesium levels and they're not perfect, then you can have compounded magnesium. How do you write that prescription? Magnesium, and here you use magnesium chloride for this purpose, 10%. I like to put it in lipoderm, Lipoderm. That's a particular base. Lipoderm drives things into the skin better. Magnesium, being a mineral, is a heavier, denser molecule. So putting it in lipoderm is great. So magnesium chloride, 10% in lipoderm. You can give biotin. It does increase insulin sensitivity. Remember that long-term use of biotin at 5 milligrams can negatively impact the conversion of T4 to T3, vanadium, and then, of course, we talked about vitamin D. CoQ10 does provide energy for the pathways. You have to have energy to make these reactions work. B complex aids in glucose metabolism, decreases sugar cravings. Vitamin C is a cofactor in glucose metabolization. Manganese aids in carb metabolization. There's your inositol, urinac. And I love the last one here. Lentils, chickpeas, and broccoli all decrease insulin levels. Other herbs that you can use for insulin resistance, fenugreek. It interferes with the absorption and digestions of sugars. Cinnamon is fabulous. Spice up your life. Have your patients spice up their life. Improves glucose utilization and insulin receptor sensitivity. Certain cinnamons do not work, so certain ones do, so be aware of that. Some people do get GI upset from cinnamon. Gymnema sylvestre improves insulin sensitivity, interferes with the absorption of glucose, has a wonderful effect, reduces total cholesterol, triglycerides, LDL, and may raise HDL, good cholesterol. It also suppresses the sweet taste of your taste buds. So if you have somebody who's hooked on sugar, Gymnema sylvestre would be a great thing to try. Of course, detoxification. Test the patient for toxic metals, chelate them if they're too high. And of course, different organs of detoxification, the liver, the GI tract, the skin, the lungs, the kidneys, the lymphatics. Does not hurt to detox these patients. Acupuncture. Studies have shown that acupuncture can have a positive effect on PCOS. It influences the sympathetic nervous system, endocrine system, and neuroendocrine system in a positive manner. And weight loss is a necessity for these patients. It improves almost everything from the psychological component to cognitive restructuring, problem solving, relapse rate. Weight loss is major. Weight loss surgery is a last resort. Studies are good. Resolution of menstrual irregularity in 100% of people, improvement in hirsutism in 75%, resolution of type 2 diabetes, and ability to stop drugs for hypertension in 78%, and the ability to stop medication for hyperlipidemia in 92%. It sounds great, but remember, when the patient has bariatric surgery, they have a really hard time having normal bowel function. They truly do. They tend to be hypomagnesic. They tend to have low potassium. They really don't make enough B12. They don't tend to make enough biotin, not enough serotonin. 90% of serotonin is made in the gut. So they will have irregular GI problems. They will have dysfunction for the rest of their life. And that's why weight loss surgery is a method of last resort. So you may need to suggest an entire nutritional program for these patients. Cognitive behavioral therapy, lifestyle changes for preconception weight loss in women with PCOS has been shown to be effective. I didn't mention gluten. A study out of England shows that for infertility, 50% of their patients got pregnant by just stopping gluten. So you can consider that. And now recently, I've started adding low-dose naltrexone for the inflammatory component. Do you continue it after they get pregnant? Honestly, no one knows. What I can say is that I am not an OBGYN. And so once the patient gets pregnant, whatever happens goes to the OB. I stop whatever I'm doing. I don't discontinue anything. I talk to the OBGYN and see what they want to continue. That includes progesterone. It becomes up to them at that point. So a comprehensive approach to PCOS is really needed. It's a huge, common disease process. The science is now here to customize and individualize care for these patients. We really can help them have a much better experience and treatment for their polycystic ovarian syndrome. Thank you.
Thank you so much, Dr. Smith. We do have some questions if you have some time.
Absolutely.
Okay, great. Thank you. What can women do to clear facial hair?
Well, certainly looking at the cause of the problem is number one, because you can do a lot of cosmetic things. You can see a dermatologist, you can see someone who does aesthetic medicine. There's different things they can do, but it will come right back again if you don't look at the cause. And so the different things that I suggested here today to help with high androgens, like saw palmetto, et cetera, can be very beneficial. So it's usually a two-prong approach. Let's help with the facial hair if it's there, and then let's go back and we balance the hormones, Make sure estrogen and progesterone are balanced, lower testosterone. And some of it, of course, is genetic. Some people do have more facial hair than others by whatever race they may be, and that has to be taken into consideration as well.
What is the first and foremost symptom of PCOS, and at what age is it commonly seen?
I see people at 16 with PCOS, so it can start quite young. Just so you know, some women do not get a full complement of their hormones until they're 18. Men commonly don't get a full complement of their hormones until they're 21. Okay. So at 16, we do a 28-day saliva test in all these patients. I honestly initially do a 28-day saliva test to really see where they are. If you just do a 1-day saliva test, the hormones jump up and down so much in this age group, it's really hard to tell what's going on. So they are going to see the OBGYN. They're going to have an ultrasound done. We're going to do a 28-day saliva test. Now, initially, do I measure homocysteine, C-reactive protein, a lipid panel if they haven't had it done, fasting insulin, etc. on the initial visit? I do. I didn't used to do it that way, but the studies now, as you have seen, are pretty convincing. I do it all at the first visit, and then I bring them back. I can't fix everything, though, on the second visit. I usually do hormones, then I bring them back for visit number 3 to look at homocysteine, C-reactive protein, dyslipidemia, etc.
Is thyroid and PCOS linked? If yes, how and what can be done?
I think as you've seen in the studies today, there is a higher rate of hypothyroidism in people with PCOS. There's a higher rate of Hashimoto's thyroiditis as well. You would treat it the same way as you would with any patient with those disease processes.
What adaptogenic herb brand company producer would you recommend?
Oh my gosh. I use a lot of companies for adaptogenic herbs. There's so many: Metagenics, Orthomolecular, Designs for Health, Zymogen, Biotics. I mean, I could go on and on. There's a lot of great companies.
How often to apply compounded magnesium?
Magnesium is usually applied once a day. Some people need to use it BID.
What suggestions do you have for women with PCOS that suffer from severe anxiety?
Well, I look at the cause of the problem. Is the anxiety because they have low progesterone? Is the anxiety because they have high testosterone? Is the anxiety because DHEA is high? Is the anxiety because cortisol is not normal? Remember that all those hormones have a balance that goes on with the neurotransmitters. So sometimes if there's a great deal of anxiety, I do neurotransmitter testing also in these patients, which is a 24-hour urine. Also gut health. Remember that there's a big relationship of what happens with hormones in the GI tract. And I mean, I have a whole seminar that I give on anxiety and depression related to the microbiome. It's huge. So there's a lot to look at there, but you can obviously start with just looking at progesterone, cortisol, testosterone, etc.
Is there something you wish primary care providers would do regarding screening for PCOS?
Oh, I wish they would do all of this. My goal in life, certainly I'm just starting my 44th year of practice starting July 1. And in all these years, I'm so thankful that I have been able to be here for a change in medicine, where the science is here to look at the cause of the problem. Do I wish that primary care doctors would all do this? Yes. So please invite them to the fellowship, because we would love to have everybody learn how to help patients from an approach that looks at the cause of the problem.
Dr. Smith, what do you do differently for normal weight people with PCOS?
Actually, nothing. If they're normal weight, remember though, they can still have abnormal fasting insulin. Commonly, the blood sugar is normal or optimal. Commonly, the hemoglobin A1C is, but about 1/3 of the time, in my personal experience, insulin is already abnormal. So if you don't measure that fasting insulin, you're not going to know that, even if the patient is a normal weight person.
How do you reduce DHEA levels?
Best way to reduce DHEA is stress reduction techniques. prayer, meditation, Tai Chi, yoga, Qigong, exercise, massage, breathing techniques, acupuncture, and adaptogenic herbs, and calming herbs if needed. I love calming herbs, chamomile, lemon balm. They really work wonders.
If a young 28-year-old develops amenorrhea and normal male hormones and thyroid and pelvic ultrasound, what to do?
I strongly suspect you did not do a 28-day saliva test. So look at a 28-day saliva test first before you call the sex hormones normal.
In acne issues, what do you suggest to clear out this once you have a HOMA and menstrual cycle regulated?
Then look at the other cause. And I mean, there's many causes. Certainly sugar, causes acne, and acne prone people change their diet and fix their gut. There's much in the medical literature, and I actually give a talk for A4M on this subject on what happens with the gut and acne. Fix the gut, it helps acne a lot.
How do you lower the levels of androgen?
All the things that I said today. I start with saw palmetto and do all the other things I discussed. I just keep adding until it goes down. Many patients, saw palmetto is plenty if you balance the other hormones, meaning estrogen, progesterone, DHEA, and cortisol, and thyroid. Also look at pregnenolone because it's the mother of that pathway, the steroidogenic pathway. So in at least half my patients, I don't have to go any farther than saw palmetto, but you can certainly add EGCG and the other things I talked about today.
What is the role of LDN in the treatment of PCOS?
It does decrease the inflammatory component. There's some, and I'm going to underline the word some, suggestion in the medical literature, the PCOS may have an autoimmune component. It certainly is inflammatory disease, as you can see evidenced by the elevation in CRP, and so LDN is used there as an anti-inflammatory agent.
And there are a lot of questions that are supplement related. Dr. Smith, I know you went through several of them throughout your presentation and have recommended some great brands. So I hope that will satisfy the answers to the attendees asking about the supplements.
For everybody else, please get a copy of my book, that came out last year, What You Must Know About Vitamins, Minerals, Herbs, and So Much More. You can just contact me at FAAFM63@yahoo.com, and we'll get you a copy wholesale since this is an educational experience. Happy to do it.
Thank you. And final question, Dr. Smith, what do you do with elevated CRP?
It depends on how high the CRP is. And this is a personal statement. People have many ways of treating it. I always start with omega-3 fatty acids. If the CRP is above 5, I do give an antibiotic. There is commonly an infectious component present, and it is empirical. We commonly can't find the infection. Studies have shown that macrolides and tetracyclines are helpful for that purpose. So I either give minicin or deoxycycline, 100 milligrams BID for 10 days. So minocycline or deoxycycline, 100 milligrams BID for 10 days, or I give Biaxin, 250 to 500 milligrams, depending on the size of the patient, BID for 10 days. And that will really lower the CRP. But again, now I have added LDN into this mix, and that also lowers the CRP.
Thank you so much, Dr. Smith. Could you repeat the email address for people to contact you for the book? Many people are asking.
FAAFM63@yahoo.com.
Great. And I did type that in the chat for everyone, so please take a look at that. Dr. Smith, as always, I would love to thank you for a wonderful presentation. You always fill us up with many of your insights, and we appreciate you sharing your expertise. We truly appreciate your time. Thank you for spending your lunch hour with us.
My pleasure. Thank you so much for the invitation, Lindsay. And everybody have a great and safe day.
Yes, and thank you to all of our attendees for joining us. We do look forward to seeing you next week. Many of you are asking if there will be a replay. The answer is yes. We will be sending you a recording of the webinar, and you can also use the link that I have shared in the chat for all upcoming webinars and all of our past recordings. So thank you again. We will see you next week.